Welcome everyone to today's session of Performance and Sports Science Study Group. We're excited to have you all here with us. I'm Daniel Yu, sports scientist for the Orlando Magic, and Nick started this group with me. Nick is the athletic trainer and PT at the University of Akron. We're honored to welcome Samir, PT with the Orlando Magic, and also our guest speaker. Before joining the Magic, Samir worked with athletes at Georgetown University and St. John's College High School. He brings a wealth of experience and expertise in integrating data and research into professional sports. Just as a disclaimer, to comply with NBA health research policies, all the data presented today is fictional and not from real athletes, but the general framework and thought process is pretty much similar. If you have questions at any point, put them in the chat. Nick and I will moderate them and we'll ask them to Samira at the end. And then at the end, we'll open it up for a Q&A. And without further ado, I will pass it on to Samir.
Thanks, Daniel and Nick. Appreciate you guys having me. Excited to discuss this topic amongst the group and looking forward to any further questions. So topic, as I mentioned, I get excited talking about tendons. A lot of medical and performance stuff I get excited about, but I think this topic, particularly over the last however many years I've been a practitioner, thanks to some great mentorship as well, has brought me to a path where utilizing ultrasound wherever it need be and talking tendons along with other tissue, which we'll discuss in here as well. But we're going to concentrate on tendons and ultrasound for today. So objectives, more or less understanding how ultrasound, musculoskeletal ultrasound is utilized in elite basketball, how we tend to use it from a testing perspective. We're going to review tendon health and how we like to risk profile it, and then improve some of our decision-making utilizing data. So one big thing to take out of this, Daniel mentioned it too, full disclosure, none of the information on here involves NBA data or images collected on NBA or G League players and is merely sample data. But I think we can take a lot from our thought processes and how we go about doing things. So MSK ultrasound in sport. Obviously, this is a tool utilized for a long time. It's got a lot more push over the last two decades, utilizing it a little bit more, especially here within the NBA. This was from a study from the British Journal of Sports Medicine, which outlines it very well on how it's used in sport. And I'm going to talk about each of these arms, diagnostically, rehabilitatively, interventionally, and research-wise. Rehabilitatively might be more biofeedback tool. Interventionally, if you're guiding a procedure, which you see a lot of our docs do, but also some other practitioners, you can use it with dry needling. And then from the research side, whether it be research or just a screening tool, measuring things, it's used quite a bit for that as well. So rehabilitatively, back in the day, there's large amounts of evidence that began in the 90s with HIDES showing its validity, measuring cross-sectional area of the multifidus and showing atrophy and low back pain patients. But it is a valid tool to utilize it that way. Again, understanding and having the training and ability to utilize it in this fashion can be a little bit of a learning curve, but once you get the hang of it, it can be a good tool. So some areas you can use for biofeedback, real-time ultrasound, or in your trunk and your low back, pelvic floor, it's used quite a bit. Even some of your hip muscles along with the shoulder as well. So do you have the low load endurance capacity to manage these things before going on to higher level things? So that's real-time. Interventionally, as I just mentioned, it can guide some of these percutaneous procedures, whether you use a dry or a wet needle. The image on the left is an example of an asymptomatic plantar fascia on the left and more of a symptomatic plantar fascia on the right. And then you see that muscle of the quadratus plantae right underneath it. And Here's a video with this just to give you an idea of where sometimes when we use needles, you can see where the needle enters here. On the top is the plantar fascia, and then you're actually trying to target your muscle that could be more of a problem with people who have plantar fascia issues or sole of foot problems. Then you're not just sticking needles in the skin or in the plantar fascia. That may not be your goal. So this makes you much more targeted in your interventions. So that's just a good example of that. Imaging. We talk about imaging in sport quite a bit. Can it improve our outcomes or ability of an athlete to endure a season? Whether you get preseason imaging, uh, baseline imaging, monitoring, serial. There's so many avenues it's utilized, but there's a lot of limitations to it. Lack subjectivity. It's not always reliable and reproducible. You really got to be uh, specific and detail oriented when you're doing serial imaging to see change. So the good thing is it can differentiate tendon pathology. Sure, there's an example of one, but the bad, it can't always guide your rehab or monitor your treatment. That being said, when you use ultrasound in a diagnostic fashion, it can be pretty specific. It's a safe and a rapid tool, point of care. You can use it statically and you can use it dynamically. So some basic pathologies that it's used often for, and you can be glad that you've used it, or uh, it's a tool that a lot of us say, hey, well, ultrasound versus an MRI, we can get into this talk, but I believe ultrasound can be much more sensitive and specific on tendons, specifically the Achilles, the patella, the rotator cuff, more than MRI. So in this case, you can look at tendon abnormalities, you can look at bone fracture and healing. For a lot of our baseball cohort out there, humeral torsion, even bone swelling within joints, integrity of ligaments. It's used quite a bit now in the UCL and monitoring it and interventionally. So a great tool, to say the least. Here's just an example of a diagnostic. This is the front of our tibia on the top left corner. It's a long axis where the probe is right on you. So you get a good view of the front of your shin bone. Uh, and like I mentioned earlier, just now, more on bone pathology. So early on, when you have bone-specific injuries or bone stress injury, you can get an early diagnosis without having to wait a few weeks for there to be potential callus formation on an X-ray. So you can really pick this up earlier. Uh, so on that, here's your long axis. Here's when you turn the probe to a short axis. Sometimes you'll see this step off or a true break in the bone. You'll see some uh, increased elevation of blood flow where you see that bottom right corner. And then the top right image is a normal side versus a non-normal side of the bone. So definitely a good tool, uh, especially in sport where you're doing things so quickly. You need quick answers. You need an, you need you're on the road, you're traveling. Uh, Decisions need to be made quickly that can impact the athlete. Moving on to more on tendons. So as we know, athletes have tendon problems. Even the normal people do. Stress to tendons impacts the pain and function of them, can be prolonged in terms of the recovery and rehab if it's not managed properly. There's interventions like injections and shockwave, but not always great success rate as managing it with load or appropriate loading principles in the weight room or an activation or micro dosing around a guy's tissue. So on the left, just sort of quick review, healthy tendons. You can see how nicely and flattened and elongated those tissues are. Densely packed collagen here on the left really looks pretty good throughout each part of the tissue. Whereas you look at tendinopathy, it's a little different, a little more disorganized. You get a little more blood flow within within the tissue. It's capillary ingrowth or neovascularization you'll see sometimes in ultrasound. Increased ground substance, more water content within the tissue. and it doesn't look as great. And you'll see that on ultrasound, more disorganized, patterning changes. So tendinopathy from its qualitative and quantitative state, and we'll get into that in just a second, can be graded with ultrasound. So shear wave elastography, we're going to talk about this because we get into this later when we start uh, profiling and risk profiling and tendon health. But back in the day, it was used, and even now, quite a bit quantitatively as a successful tool to look at breast cancer, thyroid detection, even stage liver fibrosis. And essentially, if you look at the picture, the probe uh, pulse and generates this shear wave, and that propagates throughout the tissue. And on its own, it'll analyze and pick up the velocity of that shear wave that's generated. That shear wave is then velocity is then put into Young's modulus and kicks out a nice elastogram for you, and therefore you get a measure of stiffness. So just like that, on the MSK side, it's used much more now than it ever has. When I first started doing this, uh, 8 years ago, 7, 8 years ago, it was it was not as prevalent in the MSK world and the sports and performance world, and now it's gained more. It's gained a lot more traction, and a lot of on the club side in Europe are using it more and are still looking for answers. There's a lot of things to be figured out, but one thing for sure is there's it's been deemed a valid and a reliable tool. Again, more inter-rater reliability. I mean intra-rater versus inter-rater reliable, but valid. It gives you mechanical properties of tissue, so it's essentially a true biomarker of someone's tissue. Based on the evidence, a lot of the shear waves uh, overall have shown you lower stiffness on Achilles tendinopathies and those post-rupture. So as you use this tool, and it's a special probe that you need, you can look at stiffness. Overall, all these tendinopathies on Achilles potentially will have lower stiffness. Is that always the case? Not necessarily, but that's what the evidence has shown reporting. Whereas patella is on the flip side, higher functional stiffness, more muscle activities, and excitability of a bigger motor neuron. So that's it from that standpoint on shear wave, just giving you a good background as we get into this. Now, as we discussed, testing and assessment. So this is more on that research or screening and evaluation tool. With our guys, and we've looked at it, but scanning patella and Achilles tendons, we tend to do preseason, some in-season, end of season, and get a good picture of their tissue health, which is morphology, whereas shear wave is more of a mechanical property of tissue. You have morphology of tissue, and then you have more mechanical properties of the tissue, two parts to it. And then we use that information to gain insight, risk profile them, come up with strategies to manage them if they have issues throughout the season, even prepping them each day. So, and managing their stress patterns in the patella and Achilles. So that's basically load. The reason why I have this cool picture of the car, because the analogy I like to give when we do something like ultrasound or any other testing, it could be imaging. In this case, you're looking underneath the hood of the car, right? Or we have a lot of Ferraris and really high octane sports engines, and our athletes are remarkable, but this is our chance to sometimes look underneath the hood of their car and then figure out how can we optimize that car, tune it up, make sure we come up with strategies to keep it going. So looking more into that morphology and that testing and assessment process. And like I said, these aren't images of our guys, but just examples of patella tendons. Here are some images of patella tendon, but morphology. So asymptomatic tendons with structural changes are at greater risk of 5 times greater risk of a tendinopathy. So having problems or becoming symptomatic. Tendons can rupture even without pain. You've heard of this. You've heard of this a lot where people tear their Achilles and they've never had any issues in it, but have torn it. Rarely ever do you see a tendon that doesn't have any structural changes fully rupture. There was a study that was done in college basketball, and more than 20% of the patella tendon pain and that abnormality were on these basketball players, where 3.5 times greater risk of those that were non-starters and 4 times greater risk at the start of the season, which you could imagine why that would be in the preseason. Have they appropriately managed themselves throughout the offseason? Had progressive load on the court, off the court in preparation. So all in all, it's just important to find out how much is intact. And in sport, everyone's going to have basic wear and tear of their tissue, but it's our job to come up with good strategies to keep them going and optimize what they have. So that image on the right was the patella tendon. Here's another one in comparison, left to right of the patella tendon. You can look at from the left P, that's the patella, and then those two dots gives you just width of the patella, along with you can see some of that fibrillar patterning I was telling you guys about in the more 2D image where you look on the right. That's a very different patella tendon. So I'll give you an example of just the grades of tendinopathy that can occur. And this is common in jumping athletes. Shear wave, this is the mechanical image of what you might see. Those elastograms, it gives you stiffness. This is how it would pump out on an ultrasound, and it gives you a true number in kilopascals of stiffness. After we gather all this information, we will then consider things like this, where you could put it in a nice, simple image where you risk profile them. Hey, this is mild, green, moderate, yellow, severe, red. So it's just a way to look at it. I feel like this is helpful. It's good to collaborate with the S&C staff, make sure everybody is on board nutritionally, performance, medical, have a good understanding of what you're dealing with. And it's a good way to share information and easy. So green, like I said, it's just a sample. You might have someone who's mild morphology risk for their patella, and you might put that in information, same with their Achilles. And so we'll get into this, but we'll talk about what we do in the weight room to manage that. Another way to view this that has helped me and answer some of my questions around risk profiling is symptoms and severity of the symptoms. So this is just a way sometimes you can view it and analyze it. So on this is just a graph, but if we compare some of these, again, these are sample numbers, just these are not real, but patella. So as they're graded mild, moderate, severe, how many moderate level patella morphology on ultrasound are symptomatic? How many of the mild ones are symptomatic versus severe? So it's pretty normal for all of our guys to be in at least a mild state of tendinopathy. That's normal. Well, I've rarely seen any basketball player in my history ever not have some sort of wear and tear in their tendon. It's pretty normal. But usually, hey, maybe you'll see the ones that are moderate have more symptoms, and it looks like some that are severe, maybe. So it's interesting just to view it. We like to look at it in a different way, again, to share information across each other. Stiffness values. So in a box plot, if you take all the values that you may have got from your mechanical properties that you got on your ultrasound, you look at ones that are symptomatic and asymptomatic, you put them on a box plot, you have an idea of maybe where stiffness is landing on symptomatic tissue versus asymptomatic. Now it's maybe a wide spread here on the left, sample data on the right. You have less, you always have less people who are injured or symptomatic versus asymptomatic. So it's a good graph and giving you some general outliers from top to bottom. But in the end, their median values are about the same. So with the help of people who are really good at rendering and visualizing data, like Daniel, this is an Achilles one, you can get information pumped out like this that can be helpful or not helpful. It's just more insight for you. Here's an Achilles. So again, similar values, but different in terms of 25th percentile, 75th percentile in the range that you would get stiffness. So in human movement, you'll have times where, just like this graph, the values are quite similar, but how can you differentiate potentially or find differences within them? So this is a density plot. A density plot will tell you how often a specific value is hit. So in this case, maybe you'll have here are some symptomatic shear wave values that sat between maybe 30 and 60, whereas your asymptomatic are 0 to 90. But what I would take out of it is anyone over 60 may be exclusively asymptomatic. Now, again, this is just a descriptive plot, and it's just giving you some information to make a decision. It's not predictive in nature, but just more info for you to figure out and dive deeper into. So I thought this is really cool and helpful. So thanks to Daniel on that density plot. I went a little bit too fast there. So moving forward, some questions that you may have, and I had just looking at considering all of this. Say we test morphology, we test mechanical properties. What is this telling us? How can it help us manage them? Is there a relationship with limb dominance and stiffness? In our case, basketball players, when we characterize limb dominance, it's their jumping leg. So if you have a right-handed shooter, you're going to think they're dominant on their left, jumping off more often off their left. Is that the case? Not always do you see that, even if you look at force plate numbers or whatever, but that's how we're characterizing it. Lefty would be right foot dominant. So again, when we look at this relationship and we want to look at more, this is an interesting graph nonetheless, but I think telling, this is a lollipop graph. Daniel, you can chime in if I have that wrong, but the means of the two groups are fairly similar, dominant versus non-dominant, when we look at that and stiffness, dominant, non-dominant stiffness. So the means of them, again, are similar. However, when we look individually at per player, so if you follow the dots, colored lines are individual. There seems to be a relationship. So it's just descriptive information. This can give you more insight on an individual level as opposed to looking at the whole group. So that can be helpful for you, knowing that, hey, maybe their limb dominant leg, if you're finding that it's stiffer on that side, that's when they're jumping on more. Could you expect to see that? Are there large drop-offs on that if you're looking at that over the course of a season? Or if it strays away from that range? Interesting. Just interesting. There's another question. Is there a relationship between limb dominance and a symptomatic limb? Again, sample data, like on an Achilles, maybe not at all. You might have the same amount of symptomatic limbs, dominant or non-dominant, whereas maybe patella on a dominant leg, it might be more symptomatic. So just different ways for you to answer your questions as a practitioner. A lot of times you understand, why do we do this? We just collect information on an athlete. How is it helping them? How is it helping them perform? If a guy has a history of patella tendon issues on the same leg, what is the reason for this? Do you need to look closer, not just underneath the hood of the car, at other avenues of how they move? Are there other things contributing to this? Their hip, their trunk, what have you? But maybe we can put strategies in place to keep them going, essentially, right? Tune up this car, keep it running, keep it humming along for the course of the season at its optimal. Another question I thought was interesting is there a relationship between limb dominance and tissue health? So if you think about it, hey, this guy jumps off his leg a lot more on one leg than the other. Will I expect to see more wear and tear over time from elite level basketball? Maybe you might characterize it like this too, where morphology and limb dominance, although a dominant leg, non-dominant, and there may not be much of a difference on the Achilles, where the dominant, non-dominant symptomatic is the same. But if you look over at more severe pathologies that have severe morphology or severe risk, where the patella tendon has more wear and tear, they may be more symptomatic. So again, just answering some of your questions on why. Why do we do what we do, and how is it going to help us? As we take a look at the car and underneath the hood of the car, now let's look at how we can optimize this car. If we look at them on force plates and things you can, force plate trends you can find, and how we can, like we talked about, tune up the car, keep it going, optimize it. So with tendon pathology, it's normal to see increased contact time, decreased flight time to contact time. Sometimes they'll favor their non-involved side, maybe in the eccentric phase more often. Well, interesting things seen in the past are decreased EDRFD or even con impulse, which makes sense considering your stretch shortening cycle. So just all things to consider. I know a lot of people utilize force plates in different realms and different sports, but just giving you more information to think about. Now, as we talk about strategies, how do we manage these? What do you do? Well, an in-season management is going to be different from an off-season tendon management, uh, along with even a symptomatic or an asymptomatic one. A symptomatic tendon, you're probably not going to just start hammering it with a bunch of eccentrics or a lot of stress on that tissue early on. You might put them in a stage where you can get them to tolerate isometrics before you move on to isotonics, even in season. Just a picture of this off season. Maybe you're doing a little bit more isotonics, isometrics in the off days, building tissue capacity before just jumping into plyometrics if that's something that you're considering to do. With the patella, as you look at more detailed information too, I think it's helpful to target your treatment strategies accordingly and your interventions in the weight room. So if you have a patella where it has more wear and tear on the inferior pole, then you want to consider that as an area of tissue you want to stress, right? So you might want to go in different ranges depending on tolerance and symptoms. Maybe if they're symptomatic, you're not going in as much of a knee bent position, whether it be a rear foot elevated squat or knee open chain knee extension, a leg press. If it's in the middle of the patella tendon, maybe you can go through more knee flexion to stress that tissue. So progressive range is important, and that's across the board, whether patella, Achilles, any tissue. You want to stress it through range. Some of these things with KPIs and things you consider, this has been reported quite a bit. This is nothing new. Jill Cook has talked about this. So many people, practitioners have talked about this. But how are we minimizing forces or mitigating, trying to bridge the gap, maybe you can say, of the forces on the court or in the demands of the sport? In our case, maximal jumping, maximal sprinting. We know decelerations are very disruptive. You're talking about something that's like 5 to 8 times your body weight. Maximal sprinting might be 4 times, your body weight, or max accel might be acceleration might be a little bit less than that, 2 times body weight if you look at the research. So how are we mitigating these forces? And that's where you got to make sure you're stressing it. And I don't think that's something that can be said enough with tissue, and whether it be patella or Achilles, but here's just some basics on how much load you can probably want to place on that. And with intolerance, it all matters on the athlete. But when you're thinking about, in our case, you have a 250-pound athlete, basketball player, stopping, starting, changing direction, running 94 feet. You really got to build tolerance. Many ways to do it. This is not the only way, but things to consider. Like we just talked about, what does resistance training do on the tendon? you're going to build more new collagen, densely packed new collagen. So the same methodology many of us may know, but treating the donut, not just a whole. There are maybe problematic areas on tissue, but target as much of the tissue you can, and you can build new collagen, build capacity, and optimize that car. So tissue monitoring, another area you mentioned. So for tendon repairs, ultrasound is great because you can look at the length of that tissue. On the top here is an Achilles. There's your calcaneus C. So you're looking at it from like a right to left. Pretend like this person's lying on their stomach and you're looking at the side of their Achilles. And you can monitor over time their cross-sectional area and with shear wave elastography too. So top one is a normal Achilles. The bottom one is a torn Achilles and a repaired one. So quite different in terms of the pattern of the tissue, the organization of the collagen. You can see that. Whereas here's your Achilles tendon here on the top. So interesting to utilize it in that way, but it can be as well. I mean, some advantages and disadvantages of ultrasound. Point of care ultrasound, it's non-invasive, it's rapid, not as costly. You can get some good dynamic images too. I think that's helpful compared to other conventional, advanced, and basic imaging. It's equal to MRI and some, like I mentioned, soft tissue pathology, especially tendon, and better in some areas as well. And it's not just morphology, but you can get mechanical properties. So it's like a biomarker. Disadvantages, operator dependent. Anisotropy, meaning the look of the tissue doesn't look the same across. That's a training thing, being able to toggle the probe in the right way so you get a consistent image and you're perfectly 90 degrees on top of your target. Knobology is learning how to use the ultrasound to get the best out of it. And it's not the best for necessarily evaluating pathologies within a joint. That's where you might lean to MRI a little more. There's just some advantages, disadvantages. And in summary, it is a useful tool in all those arms. And that's kind of what we like to utilize it as, and myself. I think it has its place. It's not used often. And it's not something that you go to and you have to use, but it's there. It's in your back pocket like anything else. It's a valid and reliable tool to assess morphology and mechanical properties. It's a true biomarker. There's different ways you can manage a tendon in season and off season on the basketball side. I like the fact that it's giving me some data to make decisions and optimize our care, but you don't always treat the scan, right? You treat the man, and that's important to know. A lot more conclusions to be made with more information. So that's all I got on my side. Thank you, and just wanted to honor today as 9/11. I think we have some questions, guys, right?
Yes, we do. We have one coming through here. Daniel, if you want to read it off here.
Here, he said, what do the numbers on the per player plot between dominant versus non-dominant distribution show?
But yeah, that's related to one the graph that
This one?
you mentioned.
This
Yeah,
one?
like the 0.99 and 0.86 on the top.
Yeah.
That's
Yes.
a significance value.
Yeah, that's
So the alpha.
oh,
So if there's a significant difference between groups, and just based off research, like less than 0.05 would be considered like a significant difference.
I see. I see. Just the mean, like the averages are the same or not. All right. Thank you.
Yeah, exactly. So there isn't a difference. That's why it's like so close to one.
Okay.
what else we got?
Samir, I got a question for you.
Yep. Shoot.
If you worked in baseball, and you're doing weekly UCL scans, do you think you would see a change in imaging or stiffness values leading up to a UCL injury? And one that's like a noticeable difference, not just like a very subtle change, but something that would be a big enough change where you see it and you're like, oh, something may happen, or it's like it's enough it's like a sensitive enough change.
Yeah. So that's a loaded question, but knowing my time in baseball and utilizing that tool and knowing what happens to the UCL or any other ligament over time, that yeah, I think you'd be, and we've seen this before, it changes over time with that UCL from the mechanical properties. So we know that as you stress the UCL over the course of the season, it's going to become thicker over micro tearing and repair, but it has more mobility. The stiffness of that UCL changes. Whereas, let's say in the beginning of the season, you hadn't thrown that much, you're just starting your throwing program, you're just getting back into camp, that tissue will have a different look, right? Because it hasn't gone through this micro tearing throughout the course of the stress that it's gone in season versus off season. And this has been reported in the evidence. They did a study on this years back, looking at changes in the UCL.
Gotcha. Cool.
Samir, I have a quick one. I'm curious, kind of going back to the density plot. I think that was around like the stiffness of showing that I think the patients that were more symptomatic had like a much like tighter like distribution.
Right
Yeah,
here.
I think that one. Yeah, so the symptomatic group. I'm curious, I guess, just in like the frequency that you're collecting this, if there's I guess like a like rate of change maybe from like one assessment point to the next that you've seen like kind of be the threshold where people start to become more symptomatic, or is it more just kind of case by case of like different like pathologies is going to respond differently, if you see anything as far as just like one time point to the next of kind of that being like a a benchmark of okay, this is when we start to see some pain.
Yeah, great question, Jackson. And that's it's a fascinating thing. I think it takes time for our tissues to change, and tendons specifically, if we talk about that, since we're targeting that for the talk, tissue stiffness changes over time. So what I've seen with different athletes across different sports is the stiffness in the Achilles, for example, after repair takes time to come back to the comparative side. And sometimes that's used as a marker to say, hey, is your strength where it needs to be? Are you producing enough force on the plates as fast? And that might help you and guide your rehab or on the performance side. But this is not a panacea. It's hard to say, hey, we're going to see this much stiffness change after this much time, or is this a threshold for me to potentially consider that are they going to be symptomatic, or will they go on to be symptomatic? I think that is the next. Obviously, you can see where the brain is going is, yeah, you're looking for answers. You're looking to find ways, can I pick this off? One big thing, the first part of your question, Jackson, was frequency of testing. There is situations where we've had symptomatic tendons and you'd have to review them and look at them again and again, and you're looking at them more frequently. And yes, symptomatic tendons that have more ground substance or water content, more inflamed, acute on a chronic problem, right, tend to have less stiffness, especially compared to the other side. So that's even if you're looking at it every few days. What you did notice is that as the swelling resolved and irritation and tendon resolved, stiffness started to take a peak, which is cool. But now you're looking at tissue repairing and generating those stretch shortening properties that it needs, especially in tendon, right? And that can take time. Whereas a repair, it's very different. This is months, as opposed to when it's irritable. So there's a lot more to be figured out. I think this density plot is a descriptive thing. It tells you more, especially when those things are similar in value across the whole cohort. But then I look back and say, hey, some of these guys who've had tissue or stiffness levels that have been above this number have gone on to be less symptomatic. So there's your crystal ball we're trying to find. But I think the more and more you collect data, and if you do it consistently, you might be able to find that time point. It's hard because, again, you're collecting and it's the why. You're looking for an answer. And we didn't collect it that often, even throughout in season, off season, end of season. The morphology tells us more about treatment strategies. The stiffness gives you an idea of what are the adaptations that are occurring to that tissue over time. So I hope I answered your question in a few different ways, but
Yeah, that makes sense. I actually have a follow-up kind of off like that last point, or I know
yeah.
I think later in the presentation you were talking about some of the relation to like common CMJ measures with like some like the eccentric braking or maybe like early stages like concentric impulse. Do you guys, obviously outside of like, actual like pathology and like symptoms like developing, do you guys kind of use that in like the other direction of like, oh, there's a flag that's been triggered from like this decrease in metrics for that maybe being a good time to go back and like reassess like stiffness or to like collect another image like on the ultrasound to see if it's kind of like a precursor, I guess, in like the other direction, just as far as like even kind of like that timeline of events that you just described, as far as like even when you start to see, stiffness starting to return, it could kind of be, at different time points depending on, the injury or kind of the pathology of it. So curious if it kind of goes both ways there.
Yeah, I understand your question. Yeah, looking at it retroactively after you've looked at it kinetically. So yeah, I understand what you're saying. And yes, we have looked at that and seen changes. Like an example would be, and even not here, but like as an ACL, right? So an ACL, you're using that tendon, and that has to change over. If it's a bone tendon graft, right, BTB, that tissue still has to change and adapt to these parameters. So if you look at those back in time points, their eccentric deceleration rate of force development is not like the other side. Along with their con impulse, where you want that to improve, you'll see a stiffness drop off. So you're seeing correlating. This is what's fascinating is, yes, you're looking at the mechanical properties of the tissue, and then you're seeing how this tissue is working. And you can look at it both ways. You can monitor it in different ways. So, and I think it's applicable in sport. You just have to find that reliability piece and be valid with it and consistent in a case by case basis or in a team across team screening tool potentially.
Awesome. Thank you.
Samir, we got a question in the chat.
Yeah.
What ultrasound brands are typically used for these analyses in the NBA? And follow up, what software do you use or can anyone else use for analyzing these metrics, images?
Okay. So the first question, I'm a bias because I like GE. So well, that's my go-to for ultrasound. We have a standalone console unit in the training facility, and then we have a travel laptop version as well that we travel with. So two things. However, that being said, there's plenty of other companies that have started to offer shear wave ability with like Philips and some of the other companies that are good devices. So that's all up to what you prefer as a preference for the user. The second question with respect to analyzing it, that is just training and experience. There's no software that will analyze. There's AI that's coming out now that's doing this, but and there's different cool technologies. If you guys have heard of Springbok, they're looking at MRIs a little bit more. But this is the thing about ultrasound. It's based on user, right? And your training and your understanding and experience. I can't take these images and throw them in a software and hope to gather some knowledge out of them. I look and review all of them myself. And if I have questions, I have other people that can look at it on our medical staff too with our docs. So yeah, that answers your question.
Samir, I'm curious where, or like kind of for those interested in kind of diving into musculoskeletal ultrasound, like the training that you kind of undertook to kind of learn some of those, um, different interventions and techniques, like ways that you can get some of that training.
Yeah. Yeah, I've got this question quite a bit many times. I've been doing it since about 2009. So what, 15 years. And in that time, I feel like I've gained a lot, but I have to thank that I had a mentor when I was at Georgetown, and that's Scott Apsley. I can shout out to him, but he really helped guide me in that path. He came from his ultrasound training and he had some expertise in it. So that helped, first of all, get me on the right track, getting a device. And then I took a bunch of coursework through several institutions uh, and continued to learn. I did a lot of self-learning on my own uh, and scanned a lot to get better. So that helped me quite a bit. But there's so many different institutions now who provide services and uh, tools, even books. John Abrahamson's book, he's at University of Michigan. He's like a guru of MSK ultrasound. He has an incredible book. I use that all the time. So there's different ways to go about it. You just have to scan and scan and scan and scan, and that way you know what's normal, what's not. And it's until you do that, it's challenging. But I think going back to the first part is I started it with the help of a mentor, obviously, using it as a biofeedback tool. So that helped the user side of it and the understanding of how to hold the probe, scan just like trunk and low back and multifidus and glutes and hips and subscap. And that got me better before I started taking more diagnostic coursework for it. So that's the way I would go. You can start with coursework. You just have to follow that up with consistent exposure to it. It's hard to take a course over like several days and invest a ton of money in it and then not look at it for weeks and weeks and weeks, right? You kind of have to look at it all the time. Now there's Sono Skills in Europe offers remote mentorship as well. So there's different avenues to go about doing it, and happy to help anybody who has questions about that.
Samir, in the chat, they asked any specific recommendations for a MSK ultrasound course that you found helpful?
There's several without me listing off a few. If that person who asked that question just wants to shoot me an email or contact, I'm happy to pass that on to them with several resources.
Okay, awesome. Well, we're getting close to our hour mark. We want to be respectful of Samir's time. Thank you so much for this wonderful talk. And then if people want to get in contact with you, Samir, what would be a good email for them to message?
Yeah, they can utilize my um probably my work email is probably the easiest I'm on. So I'm happy to share that or even a personal email.